So welcome and good afternoon. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today, and those of you coming in by the web as well, for this Smarter Health Seminar as part of the series on e-health strategies. Special welcome to our speaker, Dr. Judith Shamian, President in VON Canada. Dominic Covey will be giving a more formal introduction to Judith in just a minute. A special thank you to our seminar series sponsors, Borden Ladner Gervais, McKesson, Healthcare Information Management and Communications Canada, Smart Systems for Health Agency, and RIM. For those of you interested in the draw, we'll be doing the draw at the end of the seminar. Before we start, I have just a couple of announcements. First, the next seminar in this series will be held on Wednesday, May 24th. Dr. George Passett, Executive Lead of the Public Health System Transformation within the Public Health Division of the Ministry of Health and Long-Term Care, will be our guest speaker. Dr. Passett will be talking about Ontario's public health e-health strategy supporting public health renewal. We are also holding a two-day intensive workshop for health privacy professionals in Ottawa on May 25-26, and you can register for that workshop now on our website. Those of you that have been here before will know that the purpose of the eHealth Seminar Series is to examine the Canadian and Ontario eHealth strategies in detail. So these seminars give us the chance to learn more about these strategies and to critically evaluate their progress. So let's begin. Our agenda today is as follows. Judith will speak for about 45 to 50 minutes. This will be followed by a facilitated discussion where questions will be taken from the audience. Please signal me or Dominic if you have a question, and wait until we get the mic to you so that you can be recorded. For those of you that are participating in the webcast, please send your questions via an email, or not via an email, via a message, so that we can get those questions answered as well. So Dominic, will you introduce our speaker?
Well, welcome to all of you, and welcome, Judith. It's good to have your smiling face here. I've known of Judith far longer than knowing Judith. In fact, I think we really started interacting about 2 years ago. I'd heard about her work in the past in the area of nursing, and what I didn't know is she was with Health Canada at the time. I wasn't aware of that, but I learned later that she had been in the government. One of the really incredible things, if you look at Ontario's e-health strategy, is that all of the money is dedicated to our institutional sector. I don't know of any projects that leave the institution. In fact, only recently have some projects begun that are even communicating between the CCACs, Community Care Access Centers, and the hospitals, for example. When you go to the community level, there's virtually nothing. There may be some new projects coming out. So for some reason, we've not recognized some big messages that I know that Judith will give today, is that a great deal of the care occurs in our homes, occurs directly of mom and dad and brother and sister and friends and so on, taking care of each other. And no amount of effort in the systems, the formal systems, will ever prevent that from being necessary. So the question is, how do we deal with that? Well, in our institute, we made home-related, community-related health care being a primary objective. And I can tell you it's an astoundingly difficult objective. One of our objectives, or sub-objectives within that, was to somehow work with an organization whose life, its business, was in that area. And we were fortunate enough at the right moment, the right time, and I don't even know how it occurred, to learn more about the VON. And Judith said, why don't we work together? And it's been a very good start on something that's, I think, extremely important. I would like to see, personally, a huge amount of new informatics work going on in the home area. I would like to see a lot of money put into that area, and I think it'll take a while to do that. The University of Waterloo is doing very, very interesting research and development related to this area, putting sensor technology in the home, instructing people, for example, Alzheimer's patients, on how to wash their hands. Even on our website, you can see some of those examples. But this is an infant area so far, which is critically important to us. So we're extremely pleased to have Judith here. And I'm looking very much forward to her presentation. Judith is currently the CEO and President of the Victorian Order of Nurses of Canada. She was the Executive Director of Nursing Policy with Health Canada and a professor in the Faculty of Nursing at the University of Toronto. Where's that? I can't remember. Anyway, I didn't know this at all, and she's not a braggart, so you never hear these things, but she is a 1995 recipient of the Ross Award for Nursing Leadership and was awarded the Golden Jubilee Medal in 2002 by the Governor-General of Canada. So I was very pleased to hear that others have recognized your greatness. We welcome you.
Thank you. Thank you, Dominic, and it's really wonderful to be here. I was told to stand something like this, so I will try to comply. I rarely do that, but try to do it this time. What I have done with the presentation in recognizing that some of you might be very familiar with the healthcare system, but others might not be very familiar with the healthcare system, I am building my presentations starting off with the healthcare system generally, quickly moving into where the gaps and the issues are, and then turning to the solutions halfway through the presentation. But I suggest that you keep in mind some of the comments I'm making around the gaps and so on, because I'm sure I will not be touching on all of the solutions. And it will be interesting to me to hear some of your perspective, because you come from such a different, diversified group of disciplines and expertise, of how you see some of the solutions and some of the innovations that might be required in moving the health of Canadians forward. And basically, the title is the New Strategies for Healthcare in the Home. And again, I am not bringing forward a list of new strategies and saying we must do 1, 2, 3, 4, but more conceptually laying out some of the thinking and the paradigm shift that needs to happen in order to identify the strategies as we move forward. I might keep going up. It's okay. It's my fault. This will be the components of my presentation. I will be looking at healthcare in Canada, the new realities, challenge of home and community care in Canada, how can we respond? And again, coming from a very strong policy background, my perspective is around social policy, around innovation and technology. And it is really important to reinforce the policy issue, because we oftentimes stuck and wonder why certain good ideas and common sense solutions don't get implemented. And when you start to peel the onion and keep moving from one step to the next, it's oftentimes linked to policy, whether it's not held important enough or valued, or it's not on the radar screen. And finally, how do we move forward? What are the overall objectives of any healthcare system, whether it's the Canadian or any of the other countries? First and foremost is to meet the needs of people. And I know there are others who will say that there are other perspectives, like generating revenue for shareholders and so on, but I am bringing my biases and my perspective to what it is. And from my perspective is to meet the needs of the people. And you meet the needs of people by providing quality, state-of-the science, care, and services. Okay? We also talk a lot about care, but it's the evidence-based, science-based, knowledge-based care that will help us to deliver the need and the quality care that we talk about. And it needs to be done in a responsible and sustainable manner. And that sustainability needs to attend to the financial, equitable, across the sector, efficient and effective manner. And I think part of the proposition that you will see me talking about, and will put out my bias right up front, home and community care is not necessarily is done in a manner that it's equitable across the sector, efficient and effective. I think we have a system, or actually not lack of system, that tilted around the acute care sector. And I know I sound like the converted, but all my career has been in the acute care until 2 years ago. And as I said over lunch to some people, I thought I understood community and home care and where healthcare really happens. It took me joining VON and being with it for the last 2 years to really understand what will the healthcare issues of this country, and the need to understand it in order to really have the proper strategies and direction forward. And I guess I propose to you that we're looking at new realities, and those are the realities that we need to understand in order to drive the strategies and develop the strategies. In Canada, like in many of the OECD countries, and the members of OECD countries are developed countries, usually countries that have the means and the resources, or if you wish, it's the club of the rich. The needs, demands, and values of people are changing. And if you look at ourselves, our parents' generation, and so on, the way we want healthcare, the way what we believe is healthcare, and so on, is shifting. The issues are shifting. For example, if you would have looked at publications from the World Health Organization, until a couple of years ago, infectious diseases was the #1 driver of diseases in the world. And now they're predicting that the #1 driver of diseases will be chronic diseases. So the whole shift of reality is moving. And unfortunately, the healthcare system, not just in Canada but in other countries, have not kept pace with the shifting realities. Funding is not appropriately targeted to meet the changing needs. So it's a chicken and an egg phenomena. It's a lot of political agenda, a lot of policy agenda, but there are new realities, and we need to put the new realities in front of all of us and need to understand what those new realities require and how you shift what I call now the Queen Victoria rather than the Queen Mary in order to balance that reality. And here are some examples to help you to understand that shifting reality. The life expectancy has increased to 82 for women and 77 years of age for men. If you have looked at life expectancy 10, 20 years ago, it has been much, much lower than that, which means that we are having a growing number of individuals who live into their good old, ripe old age, and it brings with it different challenges. There are some myths around that the healthcare system costs a lot of money because we have a lot of old people. The older people now are healthier, but what is the reality that the last 6 months of life costs more than probably all of healthcare costs throughout the lifetime of those individuals? But the support, both from the social and the community perspective, needs to be provided to a larger group of people for more years of life. So the needs are shifting and changing. As I indicated, the emphasis on chronic diseases is very important, but you wouldn't know that if you look at healthcare expenditures in OECD countries. Okay? A lot of the expenditures are in hospitals, doctors, drugs, and if you start to take the story apart, you will see, cardiac issues are leading diseases, diabetes, cancer, and so on, that all became chronic diseases, but require more than the acute care, prescription, devices, and equipment management. They need a much more comprehensive approach. The whole notion and discussion around disease management is something that you will see in the literature if you are in healthcare. But when you turn around and say, okay, show me who does disease management well in this country, we will be hard-pressed to find a lot of examples. We're starting to have some systems like the Cancer Care Ontario, the cardiac care system, and so on. But much of it is still very much focused on the acute care component rather than the continuum of the chronic illness. Imagine a system that should be so simple, but here is a family that has diabetes. We know that it's usually a genetic family disease. They have 2 young children. Who is there to work with them to say that certain choices in the fast food industry that will remain nameless are not necessarily the right choices? How can you make food attractive, snacks attractive, and so on? Things that are basic, but will have a lifelong impact of how those young children will live out their life, what the disease, if they have diabetes, what it will look like and how they will manage it. But oftentimes as a society, because we don't have a lot of that strong approach of chronic disease management, we stay silent on it, and then we wake up one day because the child has juvenile diabetes or because something else happened, and then we deal with the disease. So we didn't manage the risk or the possible disease that's coming along. And if we have done it, we have made a significant difference to the individual, to the family, to the community, to productivity, to the economic well-being, to the cost of healthcare, and I can go on and on and on. And the philosophy and the perspective is very basic and very simple, but it's not the driving paradigm. David Foote, that many of you would recognize him from his book of Boston Echo, has some very interesting data and figures. And actually, he and I are talking about maybe doing some work over the summer to look at the whole notion of the family caregiver issue and looking at some projection of what will be the burden of managing diseases on families in this country alone and internationally. We're looking at increasing aging population, 9.9 million baby boomers in Canada, those born between 47 and 66. And as I was saying today to some people, the first cohort of baby boomers will reach 60 this year. Okay? So we are looking at a whole different type, different number, different culture. Now most of us who are baby boomers talk about what our parents need, but in no time we will be looking at the other way because we will be talking about what we need. So as I was talking to one of the policymakers, his indication was home care is not on the radar screen because most of the baby boomers worrying about placing their parents in a nursing home, but wait 5 to 10 years when they are the ones who need the services, and there is no way they want to be placed into the nursing home. So again, the shifting paradigm, and we need to understand those trends in order to be able to say what are the strategies we need to deal with. That we will have huge population that will require chronic care and disease management. Cost of healthcare gradually rises over a person's 30s and 40s, and if not too many, this is great to speak in university. Very few of us here are in our 40s or 50s, but I know that once I hit my mid-40s, all of a sudden I started to see needing to take 1 drug, 2 drugs, and now I'm up to 3 to 4 medications a day, which I really think it's crazy because I don't think that I'm entering at that stage, but the cost to the system is pretty phenomenal. Could it have been better if I would have managed my life differently? Probably. It definitely would have been better if I wouldn't be holding the positions I'm holding. But then I will need antidepressants. So. Here's some more data that is interesting in the shifting realities. More Canadians wish to receive convalescent rehabilitation and chronic and palliative care at home rather than in institutional settings. And there is almost a cultural shift that your parent or grandparent should be dying at home and so on. And we are putting that expectation on people, but we are not providing the support to do those things. So who holds the bag? And you will hear me talk a lot about family caregivers, friends, neighbors, nieces, aunts, religious organizations, or whatever. Between 1995 to 2000, there was a 140% increase in home care services. And currently, the home care expenditure in this country is around $4 billion, which is not a lot of money in an industry of over $100 billion. Half of it comes from public, half of it comes from private pockets, which is a whole other discussion I will touch on briefly. But the current projection is that in the next 5 to 7 years, that figure will double plus. That we will be looking, if I will be here in 7 years, we are talking about a $10 billion market, not a $4 billion market. And that's really overwhelming, and it's important to keep in mind that currently the private-public split is 50-50. When we look at the overall Canadian healthcare expenditure, is 70-30, meaning 70 is public, 30 is private. Home care and community care is different, and if policies don't adjust to the needs, I would suggest that the private expenditure will exceed the 50%, because we will need the care, and we're living in a country and in a society that we have the means, and we will simply go out and purchase the care. So that's a whole other shift of discussion around the policy level. Other areas that you're all familiar with, it's growing pandemic around obesity, mental health, and other areas. I am not giving a lecture on the Canada Health Act, so don't go to sleep. But the piece I'm trying to communicate in this shifting perspective is that home care is not part of the Canada Health Act. And that brings with it several issues. And I know your mandate is to look at the Ontario e-health agenda. I look at Canada, and I have been doing that for a decade or plus, and looking at international issues. But the whole notion of home care not being in the Canada Health Act brings with it a very further complex phenomena than what we see with the acute care. So each province has the power and the mandate. Each health authority, which is really the way healthcare organized across the country except in Ontario, and we will see how LHINs will play into it, have the mandate and the power to say, I'm going to give this, I'm not going to give this, that. So you might get 5 hours of care for the same area that in somewhere else you get 1 hour, and so on. The needs don't change. Okay? An elderly that fell and had a hip replacement and is not going to rehab in Quebec and goes home doesn't have different needs than an elderly that fell in Victoria and going home after a hip replacement. But the services are very different. So the medical necessary services and hospital and doctors do not play into it. The doctors do, but not the hospital and the medical necessary. And that creates a lot of issue. And it also, we see proliferation of private for-profit sector in the home care arena, and the number of players mushrooming like there is no tomorrow. And to give you an appreciation of the thousands and thousands and thousands of providers and organizations in Canada, I would tell you that VON is the largest home and community care provider in Canada, and we only have 5% of the market. Okay? And there are 4 other major players behind us that have less than 5%. So let's say that there are 15% of the market managed by 5 major providers. The rest is managed by mom-and-pop shops all over the country, or now health authorities are becoming a major player. So those of you who are healthcare professionals and those of you who are interested in technology or economics, start to think of the image of having home care in this country with so many different players. You don't know what the standards, you don't know what the quality, and it's not like in the hospital or the long-term care facility that if you miss the ball or you have problems with drugs as a care provider or so on, somebody else will come along and figure it out. There is a safety net because other people will show up and will discover that something is not right. In the home, who's going to come along? You will be long gone in many ways before somebody discovers that something is very wrong in the system. So the complexity is enormous, and no wonder that governments are trying to stay away from getting too much into it, because it will require a phenomenal, sincere, long-term, sustainable strategies to make sure that we do what's right by Canadians. I indicated the essential service component. Another issue is that the home and community care is not fully integrated into the primary healthcare system, which is, to me, conceptually, as a healthcare planner or policy person, is totally ridiculous. I go to my physician to deal with my medical needs, but there isn't an infrastructure around it that basically can turn around and the physician or the nurse practitioner says, this person needs Meals on Wheels, this person needs some physio, this person could benefit from some education. Somebody should go into the home and see what can be outfitted in the home so they manage the risk for fall or so on. It's just not there, and as much as we're trying to push it, I think there are some tiny cracks in the system, but it will, again, unless we have a significant paradigm shift, we will continue to face realities of this nature. One of the things I discovered going to VON is that we don't really talk at all in this country about the role of the voluntary sector and volunteers. If I look at home care in the VON arena, we have over 15,000 volunteers who deliver close to 1 million hours of care. Imagine the economic value of it. Imagine the social value of it. Most of the people that get Meals on Wheels by VON and others will never get it if we had to pay hourly rate and had to pay for the cars and all those things that are going out to support Meals on Wheels or visiting volunteers or hospice volunteers or volunteer drivers, and the list goes on and on. Canadians are enormously generous in spite of the fact that most of us, and this policy and general direction, we don't help them to learn how to do it, and they don't get any incentives. One of the things that we are working with governments is that notion that volunteers should be able to claim on their tax returns use of gasoline if they pay for their own car, especially with the prices that we're looking at. So there are some areas where they can do it, others that they cannot. So there are a lot of different issues that we basically have not kept pace with the shifting realities. And then currently, what's the discussion around home care? If you look at the FMM, which is the First Minister's Memorandum, it's the agreement that the premiers and the Prime Minister have signed February last year for the 10-year plan for the healthcare in Canada. Home care described as what needed to be done post-acute, which meaning when you came out of the hospital, some mental health, and some end of life. Well, based on some of the descriptions I gave you around chronic illness, around other challenges, doesn't even start to scratch the surface of what home care is. So one of the things and one of the strategies that we are working on is to have a dialogue in this country what home care in this country should look like. What is it that Canadians should expect? So you start to build the momentum, because at this point, when I talk to people, oh yeah, home care, it's post-acute, it's mental, end of life. No. That's what Canada chose to grudgingly support. But home care and community care means many, many more things. But we need to step up to the plate and describe what it is and share it with others so we can build a political agenda around it. We haven't kept up a pace with human resources. WHO, the World Health Organization, projecting that we will be 7 million healthcare professionals short worldwide. That's almost as much as Quebec's population. Okay? And unfortunately, the shortage will be bigger in the poorer countries than in the richer countries, but Canada is at huge risk. We are in a huge risk not because our governments didn't step up to the plate to open more seats for doctors and nurses. We are at huge risk because the U.S. is projecting 1 million short just for nurses. Our total number of nurses in this country is around 300,000. And the US loves our nurses. So imagine that they come for 10% of their needs, which is 100,000. If they take 1 in every 3 nurses in this country, our system will shut down. And imagine who will go. The young, who has a productivity of a couple of decades. And we see that in the African countries. The only people left are usually 50 plus, and there's nothing under it. You can't keep a healthcare system moving in that way. So what will be the strategies to deal with, I'm not going to talk about the acute care, but in the home care arena, how are we going to manage it? Some of the things we hear from colleagues, and yesterday I was in a panel talking about the drug strategies for this country, is that the healthcare system currently cannot be sustained. True or false? How many of you think that that's true? 1, 2, 3, 4, 5, 6, 7. How many of you think that it's not true? Okay, so some don't know, and the others think that that's true. I guess my answer to it is in the eye of the beholder. It's true if you look at provincial budgets, in the sense that currently in Ontario, for example, which is the area of concern for some of you or most of you, the healthcare budget is close to 40% of the overall budget. And that's not sustainable. If you do all the things that you agree with me and you say, yeah, she's right, we need to worry about home care, where it's going to come from. It's not true if you look at the GDP expenditure and so on and so forth. We have not, our expenditure on healthcare did not go through the roof. It escalated in a couple of percentages. It took a dip through the 90s when we really tightened the budget, and it came up for a bit. But we are not the most, we don't spend the most of our GDP on the healthcare system and so on. So there is room to look at things differently. And it's partially how much, but it's more how we spend it. And I think, again, I would submit that that's part of the strategic question of how we can provide the care differently. Because if we just want to do everything the way we do now and do more of it, that's not sustainable. But if we want to think of some innovations and some other solutions, both social, community, family, and technology, we're entering into a different arena. And what worries me is that when we think that it's not, we say it's not sustainable, and we stop right there, we don't think about other strategies and other solutions, and we also stop. We engage into that whole people, the next step for people is the private-public discussion. If we can't sustain it and I want more, then I'm going to go and buy it. But what if we can do it differently, and where that discussion happens? What is home care? And I'm not going to spend much discussion about it. I basically told you what the definition of home care based on the books by provinces and the federal government. But in reality, if we want to talk about home care in the comprehensive, scholarly way, that's not home care. Those are some services that fit maybe into the umbrella of home care. We need to have a conversation about home care that looks at the population health agenda. We need to buy health. That's really the outcome. We want to know that health is achieved and what are the components to it. How are we going to make sure that the population is healthy? And the population is healthy when it deals with stress in the workplace, when we deal with chronic diseases and other places. Primary health care, that's part of the home care and community health agenda. If we're talking about healthy population, how primary health care fit into this arena? Again, primary health care, unfortunately, is primary acute care. And we need to start to have the discussion about prevention and promotion. We all will be better if we understand how to maintain our health and how to reach healthy levels, how we prevent disease, how we cure diseases, and what's the rehabilitative services. I was following a former boss of mine who are in her 80s, lives in Quebec, had a double knee replacement the last few months. The way Quebec figured the system is that they have increased access and reduced wait time for knee replacement, but they eliminated the rehabilitation services. Well, thank you very much. And here I was looking at a totally cognitive, on the ball, 85-year-old woman, master's prepared, was a director of nursing for many years and so on, who basically stocked her fridge before she went in. She lives alone, prepared her home. But then after she had her surgery, she couldn't go home. She wasn't able to get out of bed, make it to the bathroom for basic needs to go home. And I was on the phone with her once or twice a day. Her network of support, in spite of her amazing career, is maybe half a dozen of us who are all over the country, except one who is in her 70s and in Montreal. And her cleaning lady became her caregiver, you know? And she said, I can't go home. And I said, so how are we going to deal with it? And we problem solved, and she ended up in a rehab setting. But the notion of needing to go through that kind of an approach, it's just not going to work. The waiting list might come down. You look good on the list, and another one might send you a few more dollars. But that person will be back in no time in emergency room with some other broken body part or whatever, or confusion because she couldn't get food, or who knows what. And you're looking here at a very intelligent, capable human being whose mother is 105. So she's very able to manage her own life, but it didn't work. So the whole notion of those things needs to be taken into account. Nurse practitioners are growing in numbers in rural areas where physicians are not available, but it still doesn't solve the problem. My comment yesterday in this drug strategy invitational meeting was, yeah, we say maybe the system is not sustainable, but we still have thousands and thousands of doctors who make you come back for every prescription. They didn't give you a refill 5 times. I go to the family health team, which is an academic center at Mount Sinai Hospital. I don't see my physician for my refill of all those stupid medications I need to take. The pharmacy calls the physician, and she renews the prescription. She gives it to me 3-4 times. And if I have a medical issue, then I go back and see her or somebody in the team. So the practices are of a nature that if we fix the practices and do it better, we can sustain the system and deliver it better. In Grey Bruce, I was talking to some of our VON colleagues. There are 50% of the population has no access to physicians. We couldn't get sufficient funding from the ministry to open a nurse practitioner family health team because they want to bring physicians into the system. And then you wonder, why do we have so many problems? So I think the issues around primary health care, community health, and social, not structured the way they should be structured. Let's hope that the LINS will do something about it, but I hope I live long enough to see it. Building community capacity. Collaborate with health, social, charitable, and private agencies. And again, that's something that we don't do. It's something that, again, I discovered coming to VON. There are tens of thousands of charitable organizations in this country. And they all work, not all, but they often work in silos. There is no integration. One of my VON branches was telling me in a community of 60,000 that there are 9 organizations that deliver Meals on Wheels, but nobody does hospice volunteering. Where is the integration? So starting to talk about strategies. Where is the leadership from within the community? You don't need government for that. We don't need governments to come and tell the charitable, not-for-profit groups how to manage it. Where is the Diabetic Association with the Arthritic Association? with the VONs, with the Central List, with all of those, the charities of this or charities of that coming together and having a conversation of how we will support our community. And again, we're talking about the strategies, how we do that, how we use technology and how we use other mechanisms to bring those solutions and people together. Caregivers, my favorite topic of the month and of the year probably. And I'm not talking about professional caregivers. I'm talking about family caregivers. In this country, all in all, there are around 500,000 licensed different professionals, from massage therapists to neurosurgeons to nurses to all those. Do you know how many family caregivers are? And it's on the slide. There are 3 million of them. And 700,000 of them provide more than 10 hours of unpaid family support to family members. And it could be the neighbor, and I'm sure if I go around the room, you each have multiple stories to tell of whether you or people you know caring for other people. So when we talk about strategies and solutions and attentions, I am here to tell you that it's not just about figuring out how to get enough professionals, but it's more about figuring out how to help the family caregivers, whether it's friends or neighbors or students or spouses, to attend to the needs in a way that they survive. So it's the retention of the family caregivers and the sustainability of their ability to do it that I worry about. Because when they break down, the whole system breaks down. % of caregivers tell us that they have health problems related to caregiving. Imagine you being 75 years old, trying to get your 85-year-old or 80-year-old spouse to get up out of bed to go to the bathroom. I can't do it at my age. Why would I think that a 75-year-old can do it? And those stories happening all the time. Now, if we just need to look around, who lives where, how, and who gets things done. 79% of caregivers report some emotional difficulty, increased stress, sleep disturbances, and other physical problems. 25% caregivers report their employment situation has been affected by the caregiver responsibility, and more than 2/3 of caregivers spend more than $100 a month on caregiving. Okay? And if you remember my comment earlier on with the growing market, the numbers will go up and the demand will go up. I think I mentioned volunteers, and I'm really needing to speed up a bit, but the whole area of palliative, Meals on Wheels, transportation, and so on. But on the other side, on the positive side, in looking at strategies, if you think at all of us who will be retiring and be looking to do some meaningful work, and looking at students that are interested in supporting and doing volunteer work and so on, there are incredible amount of opportunities, and it's extremely enriching. I was in Halifax a few months ago, and when I go to any one of our branches, I ask to meet with staff and volunteers. And I met with a group of volunteers, and there were few men in the group, and I turned to one of them who I was told was a Navy admiral or whatever, and I said, "How did you get involved?" And they said to me, "A VON person cornered me and asked me if I would be interested to volunteer." And I said to them, "What would you like me to do?" And she tried to convince me to visit elderly people. And I said, "No way. I'm not the talking type. I'm not going into people's homes." So she asked me if I would drive people. And I said, "Oh, yeah, I can do that." And he says, "Guess what? I both visit and drive at this point because the visit happens in my car rather than in the home." And he further said to me, "My wife is a retired nurse, and when I take somebody who is complicated and complex, I bring her along too." So they're visiting, and he loves it, and he wouldn't do anything else in the whole world. In our annual meeting, we give some awards to volunteers. Last year, we had two 94-year-olds that received awards. And one of them, Morris, both of them been with us for many, many years. But Morris, the night before, and he is an ordinary Canadian, and I love the ordinary Canadian stories because I think all of us who are educated and so on are full of ourselves of how important we are. But you look at the ordinary Canadians and you really realize what communities and the country made up from. The branch that he's associated with actually in Toronto, took him out for dinner. Morris gave 2 envelopes to the manager, and they both had money that he doesn't have. One for the national office and one for the branch. And then when he got up to receive his award, he said, "I want to say something." And he said, "I don't know why you guys giving me this. You're giving me so much more by letting me volunteer than I don't need this recognition. That's not what I'm doing all these things for." And I don't know what Morris did in his during his working years, but he definitely was a blue-collar worker. And you look at him and you're kind of saying, wow, this is what the stuff is about. So I think, on the other hand, in looking at strategies and opportunities, there are incredible ways to manage a lot of the situations that are very meaningful, and they are much better than governments. So let's keep that in mind as we look at the solutions. Who receive home care? And again, I shouldn't be so focused on the elderly population because we have large number of disabled, we have a large number of mentally ill, and others that receive home care. So please don't misinterpret it as only the elderly needs it. A lot of people who go through cancer care and get their chemo in the community and many other diseases. So but that's the key group that receive home care. Most common was living with spouses, and up to the third of the clients live alone, and then it increases with age. Why home care is growing? The aging phenomena is one, but reduction in hospital beds is another issue. Where the length of stay is a major issue. Most of the day-to-day care that used to happen in hospital now happens in outpatient setting. If after hip surgery you go home in 3 days and you go to your real home, I rest my case. There were situations 10 years ago even, if you had a hip surgery, you would be in a hospital for at least a week or 2 weeks, and then you would go to rehab for 6 weeks, and you will not work for 6 months. None of it anymore. We also moved a lot of the technologies from the hospital to the community. And we've simply taken what we have done in the hospital, shoved it to the home. One of my colleagues in the University Health Network, Tony Isti, is an industrial engineer with human factors people around him. And part of my education to understand this whole sector, I went to visit him. And they were doing some work on dialysis. And he said to me, and it's so obvious, but I have to confess that it did not enter my mind before. He said to me, look at that machine. The machine was built for standing individuals who can look at the different gadgets and calibrating and fixing and so on. When you take that machine into the home for a lying individual who has to manage it, and the machine beeps something wrong, he can't see what is not wrong, and so on and so forth. But we don't think and understand those issues and don't come up with solutions. So thank our God for individuals like him and others who's starting to say, are those equipment good enough for the home, and how are we going to do it? Another example that I heard from one of my managers is IV therapy, which is very common in the home. And in the hospital sector, patients are being taught of how to do it, but then they go home and they get a different equipment. So the lack of integration and the lack of the understanding of what the reality is in the community is totally unimaginable unless you live it or you hear the stories or you make an effort to tune in and figure out what are the solutions, how you deal with those things. This is an indication of how little we spend in Canada on home care in comparison to other OECD countries. And what we spend is we spend more on long-term care than on home care. So when we say whether it's sustainable or not, we even need just to calibrate how much of our investments go into home care versus in acute care. And in comparison to other countries, we spend very, very little on the home care arena. This is an indication, and the slides are available on the web, right? So you will have all the data. This is an indication of what each one of the provinces spend on home care and community home care primarily now, and what's the projection for 2010. And the first figure is the size of their population. So if you look at Ontario, the population is 12.4 million. In last year, over $2 billion were spent on home care, and by 2010, it will be over $4 billion. Doesn't make sense. The whole industry, yeah. Half of the expenditure, which will be around $10 billion, or 40% of it will be in Ontario. Okay? Let's look at the responses and the social policy development. I think I talked about it. The need to look at community partners in building high quality of life. We need to understand that the not-for-profit sector constitutes close to 7% of the GDP. So we need to understand that it's not just a cost driver, it's also an economic investment. So whether it's the professors in the university or the nurses in the hospital that fund it from tax dollars, they are also employment and an economic driver. The whole area of caregivers, and again, we're talking about family caregivers, what kind of policies we need, and we started to see the beginning policies, the federal government around compassionate leave, and we are advocating for more of it, so it's not just the end of life component, but at different stages of life. And we lag behind countries like UK, Australia, Germany, and others in our national caregiver strategy. So that's a major policy area that VON is pushing both in the service and the policy arena because there isn't enough of a voice in that arena. We also need to look at policy to reflect the community-based population health model of care to recognize the value shift from hospital to home and community. Again, it's around the primary health care, the integration, all those components that need to be discussed. More emphasis on independent living, and actually, interestingly enough, both in Alberta and BC, there is a strong push of reducing the number of the long-term care beds. Guess where those clients go, and guess what their needs are. The only real question mark is who's going to care for them. Innovations is a major answer and technology to the challenges that we face. I think the whole caregiver, family caregiver, volunteers, community collaboration, integration are system solutions we need to look at. But we have to look at innovations and technology to be able to manage the realities we're facing. Teams of caregivers responsible for health of group of people, patient-centered care. If I have to repeat those things one more time, it's so boring, it's so obvious, it's so clear, it's so not happening. Budget is provided to the team based on each patient and their health status. Income for healthcare professionals remains constant. The whole disease management, the whole managing of populations have been in the literature for decades. It's still considered innovation because until it gets implemented, it's in the realm of innovation. Support for this type of care is strong as it focuses the work of the team on keeping patients healthy, promotes disease management. Self-managed care, there has been a fair amount of discussion. Health Canada funded some experiments around self-managed care. Again, it should not mean that individuals are on their own, but most of us, especially the baby boomers, want to look after ourselves as much as we can. We don't really want to wait to go for appointments. We don't really want to do all kind of other things. Teach us what we need to do, and we will do it, but provide the tools and the information. And more of it can be done. Again, there isn't enough emphasis on it. There are no incentives to healthcare providers and to systems to do it. Home hospitals, regionalization, consumer-directed home care are all areas that make a difference. For example, regionalization been part of this country for the last 10 or so years. Regionalization means that all of the healthcare services are under the same leadership. And you see the differences. If you look at the Capital Health Authority, which is the region of Edmonton in Alberta, the percentage of elderly and children that being immunized for flu far exceeds in systems where it's a silo system, because they are able to move the resources around and shift the personnel, and they understand that if they provide flu vaccines to their elderly and children, the use of emergency room will go down, the use of critical care will go down, and then you free up resources to do other things. So all that regionalization is an innovation. We spend a lot of political capital in talking about it. It is starting to work. I think one of my comments would be that any of the innovations do take 5 to 7 years to really hold and show benefit of it. The whole notion of purchasing care in the home care sector is something that it's pretty common in Europe. We find it in Newfoundland, but we don't find it much across the country. It's a recommendation that Kaplan made. Of course, organizations that provide the care don't like that idea because that means that revenue sources get diminished, but it provides those people who need the care to take the money and purchase who they want to provide the care, and if it's a family member or somebody who speaks the language versus VON appears or CCAC appears or other options. So there are innovations out there that need to be looked at. We will see what will happen when the minister makes his announcements around the Kaplan report in the next week or so. Telehealth, telehome care, teletriage, telemedicine, telephony. Who thought 20 years ago that the tele will do so much for us? But in reality, truly, I think the technology exists. The migration of the technology and the uptake into healthcare does not exist sufficiently. And again, a lot of it has to do with lack of investment. And in this point, I think the investment has to come from government. But that's not enough. The investment, in addition to it, needs huge partnership between industry, academics, scientists, and the healthcare system. And unfortunately, the incentives are not there. A lot of, for example, home care, the monitoring in the home can be done by some of the teletype technology. And the technology exists. We know how to do it. It's been done in kind of minor, small settings. But you only get paid if that nurse arrives to that door and that home. But the same nurse, instead of seeing 6 or 7 clients a day, could monitor 25 and maybe dispatch somebody that needs that care and spend more time with that individual than the 15, 20 minutes they have in running across and burning fuel and adding to pollution and doing all that other stuff. In the last, since 85 that the CCACs came into effect, in Ontario there was minimal or no investment in any of that technology. The biggest technology that VON has is fax machines. We are the largest users of fax machines in probably this country because the material arrives in paper, we send it out in paper. It's absolutely nuts. It's absolutely nuts. But there isn't the investment in building a system, because even if VON would have been blessed with enough resources to do it, if we build a system but we cannot talk to the CCAC systems, I wasted public money or charitable dollars. Doesn't make any sense. So it needs to be a system solution, and until somebody wakes up somewhere, it's just a joke. Electronic health records, and I was very fortunate that when I was with Health Canada and David Dodge was the deputy minister, we were able to have the discussions with him around primary health care and the electronic health record and the need to build a platform. And he instantly got it. We're looking at a country that has barely 30 million population, but we must have invested tens of millions in developing all kind of systems and purchasing systems that don't speak to each other. When I saw my cardiologist the other day, he said to me, yeah, I work at Sinai, I work at University Health Network, and I also belong to a group up in the northern part of Toronto. And I said, how does work? He said, the cardiologists are totally integrated. We all belong to the same plan. But I cannot do anything for you when I am at UHN 200 meters away or when I am up north because the systems are not talking to each other. And I have to remember 10 passwords in order to get into my different systems and so on and so forth. I don't need to make a case of how ridiculous it is. But having that record and that information is absolutely essential. And we're talking about, can we sustain the system? Yeah, we can. I landed in New Zealand a couple of weeks ago in the airport. I realized I didn't have the currency. I went to the machine, put in a piece of plastic, and money came out. How complicated it is. But somehow we have not done any of it. Okay, so this is outside of my realm, a lot of the discussion around the mobile phones. All I know that with my mobile phone, I take pictures, I do all kind of things with. And 10 years ago, if we would have talked about buying technology for home care, visiting, and so on, for nurses and so on, you couldn't do it. But now with the BlackBerry and the mobile phone and so on, there's no reason why data and communication cannot be done. Telecare, Netherlands has a government policy directed at reducing the number of elderly living in nursing and residential home. And with handheld computers for electronic case management, data are collected and transferred, and the dial-up network from a point of care of central home care database. Again, for many of you, it's very simple. But we present it in healthcare arenas like, wow. Portable tablet PCs to connect and provide information. Again, common sense. The technology is there. I visited New York visiting nurses in New York City. It's also not for profit. They provide most of the home care in 5 boroughs. Their quality person can sit in front of the screen and in real time look at which patients and the deviances that's happening, and dispatch the expert to do things. Wireless monitoring units. I'm speeding up because there is a real control in the room, and that's not me. Self-care, again, the technology is there. Wireless wound care exists in this country. Again, there is a small group in BC that has developed it, and it's managed. And you don't need the ET, that it's an expensive resource. That's the specialty. It's not ET from ET come home, but the enterostoma nurse to go and look at the complex wound. The nurse takes a picture, wires it to the expert, who reviews it and provides clinical advice of how to do it. Portals for communication, medical records. Again, the new realities, as I described to you, and the solutions for it lie in social policy development, innovation, and technology. And in summary, it takes a village to care for its members, and we absolutely need a paradigm shift, and then everything will fall into place. And the solutions are there. It's not rocket science. Thank you.
Well, now is the opportunity to give Judith a rest. I'm amazed at how you got through that with your cough and everything. Really an effort. Comments, questions? Anybody would like to make any comments?
Shirley handed me the microphone. So.
Yeah.
And so I'm going to take the opportunity to ask a question. You alluded to prevention and promotion. You didn't focus on it, and I appreciate that. Do you see a role for the VON in promotion and prevention? And since you have to get paid, and typically it's done, this kind of thing is done on a population base rather than on an individual base, how do you see the VON in that role, or is there a role for the VON there?
We actually do a significant amount of promotion and prevention, but our programs, you're absolutely right, are more funded by charitable dollars, by foundations, some funded by governments, but not really. It's United Way and other mechanisms, because there isn't a strong financial government drive around those things. Hopefully that with the shift to disease management, which will start from the beginning to the end and cycle back, there will be more attention to the promotion and the prevention. But we're doing interesting things like, I know in Windsor we have breakfast programs for children. If you're going to go to school and be in school hungry, you're not going to be able to grow up to be a productive adult, and all the research shows it, than if you have a proper breakfast. Would you call it as mainstream promotion and prevention? Maybe not. You would say, oh, but that's not like exercise or anti-smoking. But to me, that's really what the paradigm shift is about. How we build healthy communities and healthy adults that they can carry out their community work in a responsible way. We have in another place clinics to teach parents how to make sure that the car seat is put into the car properly. Okay? Again, is that prevention promotion? Absolutely. And then we do other things like smart health, exercise with elderly, and so on and so forth. So the whole gamut of prevention and promotion is being done. It constitutes a small portion of our revenue, and I would love to see it constitute a far larger portion, because then we will be doing more of it. But the communities that we are in are very committed to try to advance those issues. The final comment I will make on this is that the story I absolutely love from Cape Breton in Nova Scotia, where the VON discovered that the Cape Breton, unfortunately, have some of the highest incidence of cervical cancer. So they fundraised, and they went and got a van outfitted for pap smears, and they take this vehicle to places where women are, rather than waiting for women to show up and and hold pap smear clinics. So the commitment and the understanding that VON is about healthy communities, not about home care. Home care is one thing we do, is really wonderful, and more of it needs to be done.
Question over here.
Hi. It is. Hi. You had mentioned the LHINs briefly, and I was just wondering, how do you see the LHINs, since this is the way we're heading for community health services, how do you feel that the LHINs is going to be able to respond, and will the VON be consulting with them on the innovations that you talked about today, and do you think there's going to be more of a collaborative effort?
I guess the safest answer is to say that it's too soon to know how it will unfold. I think what we see and what we hear from the LHINs is extremely promising. The challenge, I think, for the LHINs will be to see whether they can become influential in planning for communities, or they will be marginalized by acute care. And it's premature to know how it will play out. We have seen across this country, unfortunately, as much as we try to regionalize, physicians are allowed to be outside of the system. If Ontario will allow the acute care, and they're already allowing the teaching hospitals, I think, to be outside of the LHINs, then it will just be another iteration of the exercise. But if they would be able to keep the larger look, there are a lot of opportunities. Unfortunately, there is also the CCAC between the VON and the government. That doesn't stop us from being proactive and take our messages to the minister or to the LHINs and so on. But the way the system is structured, there are other barriers and controls. Now, the intent is to have a link between the CCACs and the LHINs. Ideally, the CCACs should be part of the LHIN. But again, I think they are maneuvering politics and ideal solutions. And we will see. And I think the elections are around the corner. They are all good times for all of us to have a voice. And there might be some things that they will be hesitant or reluctant to do pre-election and will do after election. Who knows? But we are playing the game.
Dr. Shamian, in your presentation when you were speaking about innovations, you had talked about a team of caregivers and how they rally around the patient in that. Would you be able to comment on how you would see, in Ontario, we are moving forward with family health teams. Do you have any hope that that may be the dream you're talking about in innovation, or how do you see that coming to fruition?
I guess my cynical answer is that VON went after around a dozen family health teams with a very multidisciplinary approach, and I think we are playing on 3 or 4 only. And the clear mandate of the family health teams, first and foremost, is to try to bring in as many physicians as possible into the family health team structure. And yes, there is discussion around the need for multidisciplinary, but it's far from, first of all, being multidisciplinary in the acute care setting. And the discussions we've been having with the family health team and with their leadership and the minister and the deputy, why don't you stretch it to include also the community health and the home care elements, so there is that flow. I think they get it to some level, But the political reality and the policy reality is that it's kind of an incremental approach in Ontario. On the other hand, you see other provinces like Alberta that just, you woke up one day and the legislation was tabled, passed, delivered, done. So we just play it in Ontario differently. And I don't give up hope because I think every step is the right step. But that's where I think we lack the large picture. And the more people understand the large picture and keep pushing the next step. So Eleanor Kaplan, when she was minister, she taught me that you kind of advance one issue. Don't advance 5 issues. The politicians are unable to manage multiple agendas. But keep taking your one issue forward. And the minute you think it's through the door, get out your second issue kind of thing. And I think it's part of the system issue. And that's why organizations like VON and others need to have that large system and keep pushing with partnership with others all the time.
Oh, I have a question from the web.
Judith, maybe,
yeah, well, I have a mic.
Oh.
Judith, maybe you can just talk about VON itself. Is it a nonprofit organization?
VON is 108 years old, not-for-profit, charitable, established in 4 cities 108 years ago to serve those that were in grave need. And for many, many decades, it was probably the only player across the country that was there in providing care, delivering babies in the home, and attending to the sick. With the healthcare shift in the last several decades, we have started to see many more players in the field, as I indicated earlier. I would say up to the 70s, VON provided a lot of the home and the community care in many of the provinces, and then the shift started. And currently we are in every province. Our largest presence is Ontario and Nova Scotia, and very clear agenda in pushing our growth in the West and Quebec and so on and so forth. And we do 50 different programs, a lot of them charitable programs, trying to serve local communities while we have a national presence.
Yes. Okay. My question was really related to an earlier comment that you made about the decrease in institutionalization being a good goal. And we'd recently seen some data from Finland where what they had done was they had literally shifted people from long-term care or nursing homes into supportive housing units. Much reduced cost and also higher outcomes and quality of life for the people who are involved. So I guess as we're talking about some of the determinants of health, housing has got to be right up there on the list. And I'm just wondering, as you're crossing the country, are you hearing anything more on that front?
Yeah, what I heard most recently, and it's an interesting discussion, that the construction industry is booming in the West with assistive housing, but no one is figuring out how they support. You know, what is the assistive housing? Is it financial assistance for some people, or is it assistance for the clients that will come in? And it's an area that we are going to start to have some discussions with developers, because the developers are into the business of construction and property management. They are not into people management. And it's not part and integrated part of the health authorities. So we will need to look at that, and others will need to look at it. The other issue to add to your comment around Europe, I was in Netherlands in the summer, and their emphasis, and when you look at the figures of the OECD, you see that in the Netherlands, the long-term care expenditure is much smaller than home care. Their intent to keep as many people as possible at home, but they also, some of the regions, not all of them, outfitting the homes with the technology, with the sensory technology, or they describe to me people who are not mobile. They are able to, from a platform, to open the door, answer the phone, get different things done, so they can stay much longer at home and they are not don't need to go into a long-term care facility.
Another question here.
Dr. Shamian, you made reference in your slide regarding the health and human resource crisis that's looming. I think it's evident from your speech today that technology is going to be part of our future. My question is how do we get there? Especially for those of us who work in not-for-profit sectors, technology is cost prohibitive, and we have funders often and sources of funds that are reluctant to step up. Just wondering if you could give us your advice on that.
I will make a couple of comments. I think part of it needs to be funding from government. But again, I don't think the government is the only solution. And I'm not one of those who says, oh, just let's keep beating up government, and because it's not realistic. I think what I have learned in my 22 months with VOA, and that partnerships is another piece of solution that one needs to understand. And partnership with private industry, partnership with academics, and so on. Very early on when I came to VOA, and I turned to Dominic and I said, could we talk about a partnership, because we all know that investing in technology is a black hole. I don't have an extra penny to buy something that I'm going to throw out, and I can't afford the development. That's not the business we are in. And I need some wise counsel that prevents me from making some stupid mistakes. So understanding how you can partner with academia and experts. And furthermore, what we've been doing is now we're working on a 5-year plan. Do I have the money to implement it? Of course not. But first I want to know what that plan needs to look like. So I don't respond to a call today because somebody thinks that they have the right solution for all of Canadians, and they will save all the money in the world just to discover 5 months into it that I burned maybe $200,000 and it's hoax, right? And so on and so forth. And Doug is sitting on that committee, having expertise internally and externally to figure out what it should be. And once I have that, I will shop it around. And basically shop it around by pressuring government, but shop it around with private companies. One of the groups that we are working on mutually beneficial partnership, which I really call strategic partnership. It's not just a vendor relationship, it's TELUS. So TELUS came to us and basically said we would love to work with VON, and we said, okay, let's look at if there is a fit, whether we have similar values, whether there are interests. There is no question that TELUS will benefit financially from the relationship, but we will benefit from it also, and will benefit from their ability to bring other private investments to the table, that then when they take it to market, there are financial opportunities there. Or collaborating with others. You know, the New York visiting nurses that I talked about have figured the answers to a lot of those things. Do I need to develop it again? No, I'm not interested. So it's going about it smartly, strategically. Take the government piece, take the private business piece, and keep moving. And I know that for VON, I cannot afford to wait for the CCACs to wake up. But the question is how I build it incrementally, and then you get to the tipping point. Excuse the...
I have one more question from the web, and that is, Judith, can you tell us the distribution of profit, nonprofit in terms of home care agencies?
No, I don't have those figures at hand, but I know that in Ontario, when the Harris government brought in Bill 13, which the CCACs were created under, the intent was to have 50-50 distribution. That 50% of the market should be managed by for-profit and 50 by not-for-profit. And when I look at different communities and regions in Ontario, in some places it's close to that, some places the not-for-profit might be 55-60%, in others the reverse. Across the country it's a different story, because most of the home care, the nursing in particularly, is done by the health authorities. Many of the regions contract out homemaking, which is the homemaking, cleaning the house, helping with some basic things and so on. So there isn't such a large private distribution across the country, but you have, as I said, there are from the 5 leading companies that do home care, 4 of the 5 are for-profit. So obviously there is profit to be made. And they have a clear presence, the We Care, the Bay Shores, and so on. It's enormously challenging because competitiveness is a major issue. An organization like VON is absolutely committed to pay pension, to have pension benefits and so on for their staff. That all costs a lot of money. In the private companies in home care, contrary to other private companies that are really have a lot of those services for their staff, you often find minimum wage, you find no benefits. The biggest challenge was through the review of home care in Ontario is dealing with the casual work concept, because most of the for-profit groups use staff for the time that they need them and don't use them when they don't need them. And it's very difficult to figure out how you're going to put food on the table when you don't know how many hours you're going to work where. So it's a challenging issue, and I hope that the report that the minister is going to bring out will deal with some of stabilizing the working conditions for all of the people in the sector, because one of the problems and one of the areas where we lose a lot of money is that the turnover is very high. People don't enjoy to work in the sector because there is no appropriate payment and so on. We have finished a study a few months ago that showed us that 57% of the people who leave the industry don't stay in healthcare. So if you think of the cost of constantly recruiting and training people, it's phenomenal.
Well, unfortunately, we've run out of time, and I was afraid of that because I know I have questions and so on. But Judith, thank you very much for this.
My pleasure. Thank you.
And Shirley will take care of the business of the day. So.
Well, we have one happy task yet to complete, and that is the draw. So Judith, maybe here's our high-tech box. And there may be names in here that are not present, so we may have to do this several times to find a winner. And I think it's, is it last name and then first name?
Robert Grant.
Robert Grant. And I don't think Robert is, no. So we'll draw another.
Okay, Mom. Anita Robbins.
Ah, yes, Anita Robbins is, I believe. Yes, we have confirmation from the booth.
Congratulations.
Yes. So, Judith, with that, here's a small gift of our appreciation for you being here today. Thank you for a very interesting talk. I enjoyed it immensely. I think we all can appreciate the work of the VON and the tasks ahead of all of us in terms of participating in home care for our family. And I look forward to seeing you again next month when we have Dr. George Pasut talking on public health. Thank you, and see you next month.